most neurosurgeons would have been vaccinated, I suppose. Yeah.
Now,
So
once you start, it will go back. We won't need to do share screen. It'll just show up on the big screen. Is that correct? It'll be a full screen.
Yeah, that's it. But if, like, I think Dr. Kobayashi has a presentation, so he will share the screen. But if you have
Okay,
a
he'll share the
presentation,
screen.
yeah. But otherwise, you just keep talking, because all the delegates who would have gone into the delegate link, they can see all of us. So there's no problem.
Got it.
Basant, there's just a little bit of echo. So I suggest that when we are on and whoever's not talking probably ought to be mute.
Yes, yes. I think which one of us can mute ourselves rather than asking the support people to mute, then that can be, so you can unmute yourself. So that's a right suggestion. I think when both of you are talking, when Nelson and you are talking, all of us will mute ourselves for 20 minutes.
Yeah. So are you saying that I can't mute Nelson?
We have, let me see, we have 1 minute to go live. Abhijit?
Yeah, hello.
Abhijit?
Yeah. We are live on YouTube, and just have 1 more minute to go.
Okay, I think few seconds to go. Okay, we go live now. Good evening in India, good morning, good night, different parts of the world. It's indeed an honor and privilege for me to invite the giants of neurosurgery. This is the webinar with a difference. You've been listening to AVM, aneurysm, skull base, gliomas, trauma, but this is something different. You listen to what the legends, the giants, how they shape neurosurgery of the world. And we're fortunate, I'm very grateful that we have two of my heroes, to whom I looked up in all my 40 years of neurosurgery career. The first mentor, and this is HMV. Some of you who are old enough like me or a little younger would know HMV, what stood for. HMV was his master's voice. This was a music company when I was in school. I think it's still on, but we have changed it to Mentors, His and Her, Memories and Views. So we have two very, very distinguished mentors today with us, Professor Robert Spetzler and Professor Shigeaki Kobayashi. Both of them do not need introduction to this neurosurgical audience, but if you don't know them, obviously you have not been in neurosurgery enough time. But just for the formality, I will introduce Dr. Spetzler is Emeritus President and CEO, Emeritus Chair, Department of Neurosurgery, Barrow Neurological Institute, and he is also the Honorary President of WFNS. Professor Kobayashi is Professor Emeritus, Shinsu University, Honorary President, WFNS, Honorary Director, Stroke and Brain Center, Aizawa Hospital, Japan. And these two distinguished gentlemen will be interacted by very distinguished chairs today. We have Professor Nelson Oyesuku will interact first with Dr. Spetzler, and Dr. Oyesuku is the Chairman, Department of Neurological Surgery. He just moved to a new department. He's a professor also of medicine, endocrinology at the University of North Carolina, Chapel Hill. He also happens to be the president of WFNS. So all of you would know him. And we have the other chair, Professor Akio Morita, who will be interacting with Professor Kobayashi. Professor Akio Morita is the Chairman, Department of Neurological Surgery, Dean Graduate School at Nippon Medical School, Tokyo, Japan. He also happens to be the Secretary of WFNS and the President of Japanese Society for Skull-Base Surgery. So let me first have the honor to invite Professor Nelson to please call Dr. Spetzler and interact with him, please. Go ahead, Nelson. The stage is yours.
Thank you very much, Basant. I appreciate the invitation, and good morning, good evening, dear friends across the globe. It is my great pleasure to kick off the Mentors HMV series that has been conceived by my dear friend, Basant. I am meeting this morning with a dear friend, an icon of our specialty, Robert F. Spetzler. Robert is primus inter pares when we consider the great masters of contemporary neurosurgery and arguably of all time. As you already heard, he recently retired as Professor Emeritus and Chairman, CEO of the Barrow Neurological Institute. I cannot and I will not go into his extensive biography. In fact, if anyone doesn't know the salient portions of the biography of this icon, then you probably should be watching the Saturday morning cartoons instead of this dialogue. Robert was born in Germany, emigrated to the United States with his parents, MD at Northwestern, neurosurgical training at UCSF under the legendary Charlie Wilson. And then inexplicably, in 1983, he took his bags, and he was off to the West into a small, sleepy desert town with an unknown neurosurgical program. The rest, as they say, is history. By dint of personal hard work, integrity, inspiration, drive, and a team of outstanding individuals, they built what became the Mecca of neurological surgery, the Barrow Neurological Institute. My job this morning is to find out why, when, where to for, what he learned along the way, what pitfalls are to be avoided, and maybe we might try our hands at what he accomplished. Needless to say, his achievements will never be replicated. Robert, good morning, sir. It's a pleasure to see you. What are you doing with your time this morning? You look casual.
Good morning, Nelson. I'm absolutely flattered by your very, very kind introduction, and I wish my parents would have been here to hear it. My mother would have smiled. My dad would have smiled, and my mother would have believed every word you said.
And she's always right. Is that not correct? Well, good, terrific. Let me kick it off, Robert. 1983, just that's almost 38 years now. Why did you pick up and leave what was already a career trajectory that was on its way?
Yeah, I was at Case Western Reserve, and I actually was interviewing at the age of 37, just not even 6 years out of my residency, for a chairmanship position in New York. And every time I went there and negotiated with the dean, it just didn't quite feel right. And as a pure incidence, John Green, who was the head of the Barrow Neurological Institute at the time, a venerable gentleman, said, why don't we have a chat while we were at a CNS meeting? And so I went up to his room, and Andy Shetter was there, one of my future colleagues. And he pointed out that this program in Phoenix really needed somebody that wanted to put a lot of work into it. And to make a long story short, I went to Phoenix, and John Green insisted that Nancy, my wife, come with me. Every visit I had in New York, which were multiple, not one time did they say, you need to bring your wife. John was very wise, because after all, unless she agrees, it's not going to happen. In fact, is when I mentioned to Nancy that I'm going to be looking at Phoenix, she turned to me and she said, if you're going to Phoenix, you're going to Phoenix without me, because she remembered going through Phoenix in the middle of July when she was 10 years old in an unair-conditioned car. And in July, Phoenix is very hot.
Yeah.
But I came, and Nancy and I fell in love with it. And, you know, it wasn't to me that it was sleepy. My requisite for coming was that it had to have a residency program, because my love of teaching was paramount, and that had to be present. The second requisite was that I would have a group of physicians that pulled in the same direction, which meant that at the time that they would be willing to subspecialize. Subspecialization is not so easy as it is today, simply because almost every neurosurgeon did spine, they did vascular, they did a little bit of this and a little bit of that. And when I visited, I met, obviously, my very good friend, Volker Sontag, who I had not known beforehand. And it was Dr. Stein who had trained him. And Dr. Stein and I were good friends because we went skiing together all the time. We had a love for skiing. And he said, there is a person in Phoenix named Volker Sontag, who I trained, who's in private practice by himself. Look him up. And I did. And he bought into this concept of subspecialization, and he took on spine and had an incredible trajectory. So that's sort of how it happened.
Wonderful. You mentioned one of the key requirements was that it would have a residency training program. Could you sort of give us a flavor for how you picked residents over the years? The BNI program became so competitive, I certainly couldn't get in, and most people couldn't get in. But what was it about picking your residents that, you know, what's the magic sauce?
Yeah, I think, first of all, I said many times as we were interviewing residents, you know, I couldn't get into this program. If I applied, I wouldn't be able to get into this program. But the residency program, I made it my number one priority when I came, to put every bit of energy into developing the residency program. So the first day I got there, it was before my official start. And so I was there at 2:00 in the afternoon, and I thought, well, I'll call the residents together so we can get to know each other and I know what they're doing, etc. Well, at 2:00 in the afternoon, there was one resident in the hospital. Everybody else was home. So you can imagine that this really turned around very quickly. And I think because we had such an attractive tending staff with obviously Volker Sontag and quite a few others, there was a dynamic young faculty that was very attractive to potential residents. And so we were able to garner really first-rate residents very quickly. And I think when you have really good residents, it makes everybody else better because they ask pertinent questions. They hold you to what you say. They question what you say. And it's an absolute joy. I've learned more from residents than from any presentation I ever listened to.
Excellent. You know, you mentioned Volker Sontag, and I know in many neurosurgical circles, people view you and Volker, the team approach that you developed, the esprit de corps, was absolutely legendary. And, you know, a lot of people try to emulate it and so on without success. Can you tell us some of your thoughts about team building, Robert? Yeah. I mean, how do you guys go about that, and what constitutes a functional neurosurgical team, and how do you dispense with egos?
You know, Nelson, I think that's probably the major factor for programs that don't work out, but it goes way beyond neurosurgery. I think interpersonal relationship skills, the ability to swallow your ego, the ability not to lash out, play a big role in whether people pull in the same direction. Yes, fear is a big motivator, but it's a motivator that leaves a bad taste in your mouth, and in the end, that motivation doesn't last. It's not a good one. Yet a neurosurgery, we've had a bullying tendency in the past, which fortunately is really not so prevalent anymore. But I think that's very important. It wasn't, Volker and I are the face of the Barrow, but there is a whole cadre of individuals. I have always said that if I deserved one honorary degree, my alma mater gave me one, but I really needed one in psychiatry, because as the head of an institute, you have the neurologists, the psychologists, the neurosurgeons, the residents, the fellows. If they have a problem, they want to be heard. And I have taken one or two of my colleagues behind the woodshed because they were talking inappropriately or acting inappropriately in the operating room or some other setting. I'm a very strong believer that you don't kick down. Mm-hmm. So anybody that disrespects a resident, as a nurse, a secretary, that is a no-no in my book. And we have never taken a resident, and we've had feedback from a nurse or a secretary that they were inappropriate.
Fantastic. You know, you devoted, gosh, I don't know how many hours, days, weeks, months to developing cerebrovascular surgical skills and teaching those cerebrovascular surgical skills. I can't imagine, as you stand on the byways of neurosurgery and you look in the evolution of cerebrovascular surgery and where it's going, does it worry you? Does it concern you? Are you confident that the future of treating patients with some of these god-awful problems is safe in the hands of the current trends, or do you wish for the days of gone by?
Yeah, no, it's actually a very serious and good point. I do not hold to the fact that the good days are behind us. When I look at neurosurgery today, I just wish I was starting my residency. When you look at the wide array of possibilities that are in front of us, whether it's in functional, whether it's in endovascular, whether it's in spine, advances are being made all the time. We have an evolution. I mean, you think of the leadership, the vision that our specialty holds, the development of stereotactic radiosurgery, all neurosurgeons. So if the time comes that we have a better treatment for an aneurysm or an AVM that doesn't require open surgery, that is a benefit to all, and I would embrace it.
Great, great. What do you think you're going to miss the most in these 4 years since you hung it up? What do you miss the most?
Well, I really had a very easy path because when I decided I would step down in the leadership position, I formed a committee and I gave them the task of finding the best person, and I did not interfere in any way with the committee's deliberation. Dr. Sontag was chairman of that committee, and they ended up selecting somebody that was trained at the BNI and that had an incredibly successful career at the University of California, San Francisco, in Michael Lawton. In order for Michael Lawton to establish his leadership, it was paramount that I was not there for a time. And so I had taken a sabbatical earlier in my career. I took another sabbatical of 6 months, at which time Michael could establish himself without the old fart being around. And when it was time for me to come back that January, I looked in the mirror and I liked the way I was living. It wasn't, I had many pursuits, many loves besides neurosurgery, although neurosurgery demanded my full attention. I decided I would just stay the way I was. And so it wasn't a sudden change. It was sort of after 6 months of really not operating. I don't know that my ego would have allowed what I had to do with my predecessor, John Green, who would come into my office, man I loved, adored, who helped me be successful when I got to the Phoenix in so many ways. But he would come into my office as he was quite old and said, you know, I am most happy when I'm in the operating room. And this same gentleman, I had to put my arms around his shoulder and say, John, you need to stop operating. He'd had little brainstem strokes, and I wasn't going to sit by and have patients be hurt within our group just because somebody loved being in the operating room. He was a perfect gentleman about it and agreed, but I know that was hard. And I don't know that my ego would have been as gracious as his in a younger colleague saying, you know, but it's time to hang it up.
What things do you recall over the years in your career that were things that you might have done differently, or pitfalls that you think you could have avoided, and how you might advise another leader or another trainee to look out for as they go embark on the kinds of journeys you did in terms of surgical career?
Yeah, a couple of days ago, I gave a talk with Anil Nanda about, as you well know, since you were there as well, about mentorship and technical excellence. I think technical excellence is something that you can insist on for yourself. And that is by going to the laboratory and doing fine procedures and really getting your tactile expertise under your belt. The mentorship that gives us pause, because none of us are successful unless we stand on the shoulders of those that came before us. And I had so many different mentors, whether it was, you know, your parents or your friends or your colleagues. Among neurosurgeons, I picked 3 from which I stole what I thought were their best attributes. Charlie Wilson, who was my chairman, and a very interesting person. He would get up at 2 o'clock or 3 o'clock in the morning and run. And he ran so much in his life that his knees gave out, his Achilles tendons, his hips, etc. But he was an incredibly hard worker and dedicated to his craft. Not the best bedside manner, but you could learn from him this dedication of hard work. The second person was obviously Yasser. I visited Yasser. I tried to copy everything I possibly could of his surgical virtuosity. I really do believe that he's the one that brought us into this microscope world that is so routine today. But his personality was one that did not engender any followers, in the sense he trained a whole generation, but not a lot of individuals. Mm-hmm. And that brings me to the third person, which is Charlie Drake. And Charlie Drake, who I adored. I did not think he was of the same virtual or surgical virtuosity that Yasser was, but he was somebody that anybody could approach. If you were a medical student, you would not hesitate to talk to Charlie Drake. And he was so gracious to me when I was an absolute nobody that I tried to remember to bring that sort of grace to others. And I copied that and hopefully was successful to at least some degree. So for leadership, I think if you follow the golden rule of treating others as you would like to be treated yourself, you're way ahead of the game. It's like raising children. I always tell the residents or fellows, if they ask me about raising children, I say the 3 T's: tolerance, tolerance, and tolerance. Never close the door, never close the door. And the same thing with leadership. You have people that are working with you that are absolutely brilliant, but they may not have the social skills to really get along. And as a leader, I think your job is to keep their skills and tamponade whatever it is that rubs other people the wrong way.
Well, we're closing. Thank you, Robert. We're closing in on our 20 minutes of allocated time. So I want to be respectful of others. Any parting statements to our young neurosurgeons all over the world who have tuned in this morning, waiting on every word you say? Can you give them a going away parting statement or snippet that they will remember for time, please?
Very sweet. I've always thought that of all the mentors that we have that are so critical in developing our own attitudes in our profession, is the key is to steal from everybody what you like and reject what you don't like. So they can take somebody like you, who is now the president of the WFNS, who has been so successful in the United States, and follow not just your path, but also the way you interact with people. Because the bottom line is how you treat others. That's how you're going to be perceived, and that's how you're going to be successful.
Thank you very much, Robert. Let me hand the mic over to Basant, who I think wants to ask 1 or 2 questions to wrap it up. We wish you a wonderful, fruitful, healthy retirement. We know you will enjoy it. Give our best to Nancy, and Godspeed. Thank you, Robert.
Thank you.
Thank you, Nelson, for doing a tremendous job. And thank you, Robert. As always, it was a pleasure and honor and privilege to listen to you. Let me ask you one thing. Nelson did ask, but you did not answer. I suppose you don't have anything to change. Do you think anything you did or did not do, you would do differently? He did ask, but you bypassed that question. Let me ask you again that one.
Yeah, I made so many mistakes that I sort of didn't want to start on that, because you don't have enough time to consider. But I would say that if I've made mistakes, it's intolerance. Maybe I could have been more tolerant. But I in it all, in when I look at my life, and I had to do it over again, I absolutely would.
Okay. Now, I know you were ahead of times, so you had a problem because many of your contemporary did not believe that this could be done. I know that. I have been told by many of your friends that you had a problem because you probably you did things which nobody thought could be done. So people didn't believe it. So how did it affect you that time?
Yeah, I think, Basant, the question really had the answer in it. I didn't know it could be done. It wasn't a matter of some sort of incredible insight that allowed us to build the BNI. What I did do so, however, before I accepted the position in Phoenix, I picked out the individuals that were there to come together as a faculty, and we would have meetings like until 2 o'clock in the morning. And what I did know that I wanted to achieve was a faculty that was subspecialized. And I can't tell you how much discussion we had for people to buy in. These people were in private practice. That means they had to give up a lot. And then for them to consider giving up something that they really enjoy doing in order to concentrate on something else was difficult. So it was a carrot and stick. My carrot was that if you take this subspecialty on, you will get all our patients that have this particular problem, and you will become a leader. If you don't want to do this, then I will bring somebody in to do this and take your place. And everybody in the end bought in. I mean, I had absolutely terrific colleagues.
Okay, Akio, you want to ask any questions, comments to Robert?
Yes, thank you very much, Dr. Spetzler. I had a question about your in training time, limit in your country. And now in Japan, same thing, similar thing is coming. Lifestyle change. We need to limit the time that the resident should work. In the 48 hours a week, is that enough to develop such skills in all, directions? How do you think?
That's a tough question. It's something we grappled with. And when you look at hours, how they came about, the restriction of hours in the United States, they came out because they did some sleep studies in the East. And they looked at internists, and they looked at surgical specialties. The problem really was that there were quite a few surgical specialties, not just neurosurgery, but others, in which they exploited residents, in which residents were used as a workforce, not to be teaching them, not to be grooming them for their specialty, but to get work done, because it was a cheap labor force. So there was some requirement. Do I think 48 hours a week is enough? Absolutely not. But a reasonable amount of time, now in the United States, it's 80, and there's some exception, it was up to 88. I don't know. When I look at our current residents, I am absolutely in awe with their dedication, with their intelligence, with their enthusiasm. I don't think that's going to change. And so as long as we get the right kind of people, the hours that they spend officially may be set, but their reading, their attending, their inquisitiveness to advance their specialty, it will remain there. Neurosurgery is not a job. It's got to be a passion.
That's true. Because same. Oh, Nelson, do you have some words?
No, go ahead. Akio, go ahead, please.
Yeah, and we had a similar situation, but it's not good resident. Even she or he's not aiming to neurosurgery. They want to stop in the middle of a surgery. This is time. I'm going back. So you finish these cases and things. It's very bad, But I don't want to.
Akio, this happens in Japan. This happens.
It's getting me a rule now.
Yeah, this happens very, very routinely, I'm told, in Europe now. From people of some of my colleagues, they say, now time is over, so I have to go. And they have to go because there's the rule. Otherwise, the department, the institute can get sanctioned. So that's the problem. Yeah. Let me close before closing. I just want to make a statement. The pandemic, there is a tremendous change in the human behavior because of the pandemic. I don't know whether you have heard the news. There are hundreds of thousands of young and middle-level people who have resigned from their jobs to go into their hobbies, greener pastures, doing something much less, let me put it, the rat race, not to remain fast all the time. This has changed, and these are figures which are unbelievable figures, which are official figures which are available now. How many people have resigned and not gone back to their old jobs whenever they have time to go back? So, do you think this is going to be changed? This has changed in my life. I'm telling you. But I never had tea in my house in my 35 years. Always it was tea in the hospital, but now it has happened. So I enjoy it now. So I don't know.
Basan, one of my passions is reading history. And whenever I'm with a colleague who's discussing politics and who is lamenting the fact that it's so divisive and it's never been worse, when you read history, we are no different than what happened 100 years ago. And I think we will find in neurosurgery the same sort of ups and downs, the same sort of lamentations. I'm much more of an optimist, and enjoying quality of life is not a bad thing, right?
Okay. I think let's finish with that I think optimistic note, and let me invite Professor Akio Morita to interact with Professor Kobayashi, again one of my all-time heroes and legends in neurosurgery, who again doesn't need any introduction. But let Akio take it over, please. Akio, stage is yours.
Hi. Thank you, Basan. And this is a great honor for me to introduce the Eastern giant of neurosurgery in Dr. Shige Kobayashi. As everybody knows, he's very sincere. His most typical feature is very sincere and very modest, but he's very strong leader in Japan. And he has been, chair of the Shinshu University, but he taught a lot for me or for other young. I'm not young anymore, but as a young, Japanese neurosurgeons also in other, developing countries. And I just introduced his career briefly. And he's a graduate of Shinshu University in 1963. Then, and 2 years later, since 65 to 71, he was at Mayo Clinic under Dr. Sant and Dr. Lawton. And then he was trained there, then developed his career, then went back to Shinshu University, and he was associate professor under Professor Sugita, and he succeeded Professor Sugita. Then he was chair of the Shinshu University since 1989 to 2003. Then his job was succeeded by Professor Hongo. He's another giant in Japan. He trained good neurosurgeons in Japan. He has been president of Japanese Society, Neurosurgical Society, also Japanese Congress of Neurological Surgeons, and he's in the executive committee of Congress of Neurological Surgery in the United States. Also, he has been a treasurer of WFNS in 1997 and vice president and honorary president now. And also he received that Lifetime Service Award from WANS in 2011. And Dr. Kobayashi will talk about his career and also how he developed his surgical skills and philosophy in the field of neurosurgery. And he will talk on his slides. So Professor Kobayashi, can you put your slides on?
You can share your screen.
Thank you for your kind introduction, Professor Morita. Thank you for the opportunity, Dr. Misra. I enjoyed Dr. Spetzler's talk very much. So I felt very lucky. I have known him for many years. My talk today is the memories and views from my neurosurgical career. Because I'm not as well known as Professor Spetzler, I can show you some of my CV. As Professor Morita said, I trained in two U.S. hospitals during my career. One at the U.S. Naval Hospital, Yokosuka, and one at the Mayo Clinic. And retired, stepped down from the chairman 2003. Now, later on, I have traveled various countries, like you see here, for a meeting or some short stay. As to my neurosurgical career, as you see here, blood column, my career roughly correspond to the era of microneurosurgery. You see some of famous names in the history of neurosurgery in this modern times. Now, I have three mentors, and these are Dr. Sant Roten at Mayo Clinic and Dr. Sugita. These are the time I was working with them, 3 years, 6 years, and 10 years respectively with them. Of course, until this, I collaborated with them from time to time. Now, special memories concern time, person, and places. As to time, it coincided with a transition period from macro to microneurosurgery. I correspond to evolving period of microneurosurgery and also with the skull-based surgery. Now, this is a list of my special memories, like how I started neurosurgery, surgical experience at Mayo Clinic, memories of microneurosurgical anatomy and so forth. How I started neurosurgery, remembering medical school days, I had a lecture in which Kahar said a lack of regeneration of the central nervous system, which prompted me to study neuroscience. Secondly, increase in traffic accident in Japan in that time, especially head injury was miserable, which prompted me to choose neurosurgery. My objectives at starting my neurosurgical career listed here. One, I wanted to be capable to perform brain surgery. Secondly, be proficient in perioperative care of the patient. And thirdly, I wanted to perform clinical research, which is applicable for clinical practice. You see, at that time, neurosurgery was very advanced in the United States. As you see here, WNS started in 1932, while Japan Neurosurgical Society started in 1948. So I went to the United States, Mayo Clinic. And some of the memories here. One, about the Mayo Clinic, it had a large volume surgical cases, as everybody knows, and wide-based neurosurgery surgery training we could get. And thirdly, there were excellent facility and faculty members. My career operative cases, not so many, somewhere around 4,000 cases. The largest number I had was at the Mayo Clinic during my training at Mayo Clinic, and secondly, the time with Dr. Sugita and during my chairmanship at the university succeeding him. So this is my idea as to how to improve the operative technique, my vision. One cannot become a good neurosurgeon only by observing surgery. Secondly, one has to actually participate in surgery and perform a certain number of cases under supervision. And thirdly, observation of expert surgery is most effective and important after one has performed a certain number of cases by himself. So this is the experience with basic sciences. When I started my residency at Mayo Clinic, chief at that time, Dr. McCarthy told me, go study basic sciences first and brush up your English as well. I was non-native speaker of English, but anyway, I spent a couple of years in basic sciences, studying neuroanatomy and listening lectures and doing cadaver dissection. autopsy every day, brain cutting, and attending neuropathology lectures. And neurophysiology, nerve conduction tests were easy, recording all the patients of the Mayo Clinic. We are encouraged to do research for the degree. Dr. Roton was in charge of resident training, especially for research program. And he said to me, why don't you study nervous intermediates of the seventh nerve with me on Cordova? Another thing I chose to study was the neurogenic control of cerebral circulation with Dr. Waltz. Dr. Waltz was the neurologist and the researcher. So how do you like to study anatomy of nervous intermediates with me? I studied on nervous intermediates and Cordova dissection and wrote a paper with Dr. Roton in 1968. And this was actually the first paper in the entire series of microneuropsychiatric anatomy of Dr. Roton. With this, I became interested in microneuropsychiatric anatomy and later on an acoustic tumor surgery. Well, during the time at Mayo Clinic, my training, we had a Professor Yasagio visiting as a visiting professor in the lecture, and in which he said, I studied anatomy in the laboratory whenever I had time. And this was confirmed when I interviewed with Dr. Yasagio at the Japan Neurosurgical Society meeting 2002 in Yokohama. Very important message. Second mentor, Professor Sant, in his nationwide TV program, he said there is no margin for error in neurosurgery, zero margin for error. I was impressed by his devotion to his determination as a dedicated neurosurgeon and editor of Journal of Neurosurgery, for which he worked 1 week before his death. Dr. Sutton, as I see him, was one of the best microneurosurgeons, especially vascular surgery in the United States at the time. Dr. Morita,
Yes, I want to ask you about this. Yes.
Going,
Thank you very much.
I know you spent some time with Dr. Sant at the Mayo Clinic.
Yes, I was actually I was his last resident in 1992, and I was in Mayo since 1989 to 1996. But he passed away in September in 1992. But I had a lucky, and he could operate for more than 30 cases during January to March when I was a resident to him. But he was, of course, he was very sick at the last time. And how was his spirit was very strong, even at that time. How was he when you were, assistant, when you were resident at Mayo Clinic?
Well, Dr. Sant, Well, at that time, Dr. Sant was very energetic and working very hard. And, one time on one Christmas Eve, I found doorbell rung at my apartment. I opened the door to find that Dr. Sant was standing there holding a bottle of bourbon whiskey as a gift to me. He said, thank you, and left. And he was a kind of shy person, but he was before his career as a neurosurgeon, he was in Korean War as a army officer. He looked stern looking, but he was very kind and very considerate. And after returning to Japan, I visited Mayo Clinic from time to time. So I don't remember how he was getting weaker over the years, but it wasn't that difficult to compare. But I remember he was always active and operating like he was really during the time I worked with him. One of his regents at my time was the David Pipgrass, and who succeeded Dr. Sant as his other chair of the department.
Right. And how was your colleague when you were at the Mayo, and how did you interact with you?
Well, they are very friendly, and we work together. We are very, very busy. You know, the night duty was every other night. We had to do night duty.
No
and
8 hours rule. That's right.
So wasn't much time to get together and enjoy. But you know, once in a while, we had a party, and they drank a lot. But at 12 o'clock, they returned home, and I drank much, and I couldn't get up in the morning. But our colleagues, came to the hospital right on time, and they worked very hard as usual. Different physics. My memory.
Yeah. Japanese are weak a little bit than and Caucasian people in the alcohol wise. But anyway, can you go ahead with with your experience with Dr. Dr. Sugita and other people, and also about your philosophy?
The time I was associated to Professor Sugita, or the time of the evolving time of microneurosurgery. I spent with him for 10 years. And memory during a co-working time with Dr. Sugita, this. The first Dr. Sugita said to me, let's orchestrate the OR with all staff in OR. Secondly, let's automatize surgery with robotic concept. And let's think innovation and application always. Now, these are Dr. Sugita's innovation OR machines and instruments, and operative table, head frame, operating microscope, operative chair with head pedal like this, foot pedal controlled all the motion of these machines, very robotic. And 3 surgeons stereoscopically seeing the operative field in operation. And later on, after Dr. Sugita left, automatic armrest, tele microsurgery research we did with the governmental subsidies. Now, after he left Shinshu, this was a mature stage of microneurosurgery, and what left and expected for me to do in this maturing stage of microneurosurgery. And this is what I thought. 1, problem-solving method based on difficult cases such as aneurysm and so forth. And secondly, developing my own philosophy of all possible based on surgical cases. I'll tell you that in a minute. Problem solving. Some examples about aneurysm. Dorsal-IC aneurysm, carotid cave aneurysm, reported that in 1986, 1989 respectively. They are called different names by different authors. Anyway, these are the aneurysm in this location. How I developed my concept on carotid cave aneurysm, I had a failure case experience in 1981 using a clipping aneurysm. The clip, of course, ended up at the conclusion of the parent ICA problem. So we went to the laboratory, did a cadaver dissection, designing a surgical approach, and developing modified clip specific for carotid cave aneurysm. Now, like this problem occurred, then you think about solution, the appraisal of this, you appraise this again. If it's something lacking, you think again. Now, as time goes by, there will be new methodologies that can be applied to further improve whatever half technique and concept and instrument. So finding a solution, knowledge, concept led to an increasing number of the cases and reports. As you see here, we reported 8 cases in 1989 and reported 231 cases. 2006, paracrine of the aneurysm, most of which were carotid cave type. So it is important. If it's something happened, it's something designed, then cases all of a sudden increases, report as always. Second one, I thought about this, developed my philosophy, if all right,
Let
possible.
me stop here, Dr. Kobayashi.
Okay,
Can I ask one thing about that? I know that Dr. Professor Sugita was very innovation. He likes, good amount of, he innovated lots of things and also taught you and taught us how that innovation is very important. And you are also involved in the developing robotic system. How do you think about the robotics in the future of the neurosurgery?
well, I'm
what's the
sure,
role?
yeah. Well, I think Dr. Morita is doing a robotic now in your way, so it's something better to ask you instead. But anyway, I'm sure it will continue to develop and become practical. As we see that Da Vinci surgical system are getting widely popularized over the world. When we develop new robot, this is a robot we developing. This is the master and the slave telemicros neurosurgical system during 1990, which was the time also that Da Vinci was developing. We had a great hope in the future at that time. Initially, this project was started, as I said, by the government support, but because of the limitation of the Japanese law, further development to apply to human neurosurgery had to be suspended, unfortunately. I believe the law should be amended to cope with this problem in the future for the sake of human application. Well,
yeah, I also strongly agree that in 10 years, maybe some of the most sophisticated part of surgery should be assisted by robotics. It will come, and hope. Yeah. So please go ahead about your philosophy in the last part of
if it is philosophy, yes, it's well, this is the beginning of this philosophy development. At Mayo Clinic at that time, one of the great surgeons dealing with acoustic tumor was Professor McCarthy. And his facial function preservation rate was 37. He was, in the transition time from macro to micro neurosurgery. And after I started to do acoustic tumor surgery after 1978, the result of that work was published in Journal of Neurosurgery in 1982 with the result of functional preservation of facial nerve of 70% with a tumor bigger than 3 centimeters. Why is that difference? All in under microscope. The basic procedure for tumor surgery at that time at Shinju University was that we operated the patient with the patient at the lateral portion. Most of the institutions in Europe and America, they were using sitting position. And the monitoring, facial monitoring, we used sound and continuous facial monitoring, and a CNAP as needed. And intraoperative head rotation with theta frame is very characteristic and very exact and useful. And this may have contributed a good result of surgical cases of vestibular schwannoma. Now, over the years, 504 cases we operated at Shinju University with the facial nerve preservation rate somewhere around 93%. Then during this course, I thought about what are the tips for acoustic tumor surgery, vestibular schwannoma. And these are the 10 tips. I call that 10 commandments. Some kind of antagonizing word I use for phrases, haste make waste, quick and slow, and so forth. I reported that at the World Federation, World Neurosurgery Congress in Istanbul, 2017. Then I pick up some of these tips for general neurosurgical use. And this is the list of these 4 or 5 tips. Haste makes waste, quick and slow, believe and doubt, fear and fear not, retreat and unusual difficult. I wrote this thing in Chinese with consulting with my Chinese neurosurgeon friend. Anyway, one, haste makes waste. Too hasty surgery can produce complication. Too slow, overly prolong the operative time. So plan no other commitment on the day of a critical surgery. You should spend enough time for surgery as needed. Second tip, quick and slow. Keeping surgical rhythm is very important. Quick in opening and closure and bulking, slow and meticulous during procedures for vital structures, especially semicircular nerve complex, and these help shortening the operative time, of course. 3, believe and doubt for exact identification of nerves. Do not rely on one method only. Use both anatomical and monitoring information because anatomy may be distorted and the nerve stimulator may be out of order. Stimulation may not be working properly. Check if muscle relaxant use when you stimulate. Well, this is the normal anatomy. I happen to realize that when you operate a patient in this lateral position, these components of 7S nerves twist the appearance from brainstem to periphery. And fear not getting close to the nerve. You know, sometimes dissection often easier when closely done. Don't be afraid to getting too close. Of course, you have to protect it. Retreat at an unusual difficulty, extremely tight brain at opening dura, interrupted swelling of the brain. Possible cause for these swelling, inadequate patient positioning, anesthetic problems such as ventilation causing hypoxia, overhydration due to infusion, intraoperative hematoma may have been happening, venous thrombosis may be developing. So fourth, in summary, my memories and views are presented revealing my neurosurgical career. They are somewhat sustained with Japanese mentality, but I believe may be interesting to you and useful as a reference. Take-home message. 1, we stand on the shoulder of a giant. Then we develop our own practice and concept. And 3, instead of paying back, I think paying forward to next generation, paying it forward by Catherine had said. And this is really the essence of the paying back. Isaac Newton said, if I have seen farther than others, it is by standing upon the shoulders of a giant. I think it's great to have a good friend. I enjoyed Robert's lecture earlier today. Thank you very much for your attention.
Thank you, Professor Professor Kobayashi and Shige. And it's a very nice summary of your philosophy and your how did you develop your skills and your career. And it was very nice. Thank you very much. And last part, of course, it's part of it is kind of Japanese philosophy, but I think all our others today and also maybe listening people, our goal is develop a new generation and train new generation good neurosurgeons, and no matter how they can work a week. So, and that might be our goal. Thank you very much. So, and I'll give you a mic to Basan.
Yeah. Thank you for very, very nice memories. Really enjoyed it. I actually have heard this talk this on your acoustic 10 commandments. You gave it also in, I don't know whether you remember, you gave it in Korea, in one of the skull base, the AOSBS, Asian Oceanian skull base surgery also you gave that talk.
Thank you very much
So
for remembering.
I had photoed that, so it is there.
Dr. Kobayashi, you can stop sharing your slide. You can stop your sharing your slides.
Okay.
Yeah.
Yeah. So the one thing I would ask all of you is, both Japan and United States, of course, is very, very developed and all the facilities are there. So when there may be many young people listening to you all about in countries which is developing, where the facilities are not, that much advanced of robotics or all this monitoring. What would you say? I think, I don't know whether Dr. Spetzler is there or not there, but I can't see him, but I can see you, Dr. Kobayashi and Akio Nelson. What would you advise? How much is there? So, Robert, I mean, what would you advise for a young neurosurgeon in a developing country with limited resources? I would say, I don't know whether you have met or talked to Dr. Ramamurthy when he was alive. Dr. Ramamurthy always used to tell us that don't get disappointed that you don't have this or you don't have that. You can do most of surgery, good surgery. You have to have a microscope, which actually he picked up later in his life, and he was an expert in stereotactic initially, and the aneurysm actually that did not develop in India so quickly because of his views that aneurysms were uncommon in India. But he always taught us that whatever you have, use to its best, capacity. You have a microscope, you have a drill, you have a bipolar. Most of the things you can still do it. There are many young neurosurgeons who will be in the developing country and listening to Dr. Kobayashi, Dr. Spetzler, Nelson, Akio, very, very high tech. What would you advise them?
I agree completely. Necessity is the mother of invention. And when you think back, for example, using the giggly saw, it's a great saw. It makes a very, very small cut. It's a really nice way to bevel the bone. And there's absolutely no reason that you can't do as good of a craniotomy with that as you can with a Midas Rex drill. So I think absolutely you use what you have and you do the best you can.
So I think it's...
Basant, I remember the time I was on the AC committee of the Water Federation, WFS. That time, Professor Sami proposed an idea to make a basic neurosurgical instrument set and distribute to developing countries. And many countries, neurosurgical society attended this proposal. Of course, Japan also donated many, basic instrument set. This is the way we should do. And then secondly, maybe we have to do something like this for microneurosurgery.
I think it's good to aspire, good to see what can be done, but not to get disheartened because you don't have something. I think that would be the very important thing for a young neurosurgeon. See, okay, this is so much there, I can't do anything. I mean, that's not the way to go forward, I think. Any final words, all of you, starting with Nelson, the president of the World Federation?
Yes, thank you, Basant. I think this is a wonderful series. I think we should continue it and expand it. I think there's much to learn from the greats, Shige, Robert, and countless others that are still between practice and retirement and beyond. And I think we should accelerate the pace at which we do this because none of us are going to be here forever. And I would like to get these testimonials on record so that they're available for posterity. So please carry on this wonderful series.
We are recording it, we'll pass it on, and the next one will be Roberto Hiros and Graham Teasdale from Glasgow, and Roberto Hiros from US. They will be the next, and it will be the next December. We want to do it once a month so that don't overdo it. And the first Friday would be the usual time unless until the mentors are not available. But this is planned already. But final thoughts, Robert and Sigate, please go ahead before Akio to conclude.
Well, I really enjoyed listening to my friend Shige. We've known each other for way too long because that only reflects how really old we are, or at least I am. Shige remains young forever.
Oh,
No, I
thank you very
enjoyed
much,
this.
Robert.
And I look forward to watching others.
Yeah. Thank you very much, Basant. Organizing this meeting. I enjoyed it very much today. I learned a lot from Roberts. Thank you.
Akio, you can conclude.
Yes, and in Japan, it's a very nice season of foliage. It's a very beautiful, mountains. I heard that Dr. Kobayashi went there because his wife is just asking, insisting to go today. So she was there. But it's very nice to look for you two, two giants, and relax and sit back and, spending a good life and satisfied with your career and, achievements. That's a very nice, our, good bait for young neurosurgeons, I believe.
I think, yeah, I think this is an honor, and I'm so happy that you could join us, and so many young neurosurgeons would be so happy to have heard you. Thank you very much. I think time to leave, and I let you go and relax. Bye-bye.
Bye-bye.
Thank you very much.
Bye-bye.
Bye-bye.
Thank you very much.